impressive program called Childsmile. Alex, we'll hand over to you.
Thank you. Hello. I'm going to present the results of our evaluation of our national toothbrushing programme. Next. And supervised toothbrushing was one of the earliest components of our national Childsmile programme. Next. So I'm going to present some published results from our evaluation, and that's in J. Dent Res. If you do look at if you do look at this paper, don't forget the appendix, which has quite a lot of information on it. So some dates. Next. So some milestones. We identified that oral health was to be a priority for children. It was also decided in Scotland that we couldn't have fluoride in the water. So then an oral health action plan was developed. Next. So Childsmile began rolling out in 2007. Then in 2011, the full rollout was complete. But the previous toothbrushing rollout started in 1986 in Lothian, then rolled out Shetland, Fife over the years, then Ayrshire, then Lanarkshire, then Fleece and Galloway, Forth, Glasgow, all the way down to 2001 to the final one in the Western Isles. And the toothbrushing gradually increased in each health board differently and at different times. So we were able to access that data essentially at a health board level. And the dental decay data from the National Dental Inspection data is also available in these years. So this is the DMFT data that we used to link in with the toothbrushing. So next. So this is the raw data, mean DMFT in each health board over time. So that's a bit confusing. So next. So then we set the calendar time to be time 0, which is different in each health board. Next, then we smoothed it into 3-year groups. Now, as you can see, next, then, and then again, actually DMFT was rising prior to the beginning of the rollout, which helps to suggest that the toothbrushing results are against a secular change that either was flat or slightly going up. So, and in terms of results, so the drop in DMFT was 0.45, 0.41, went up to 0.73, then became nearly -1. And in more affluent kids, the drop's 0.4, but for the more deprived kids, it's much higher then. Next. So the most deprived kids, the drop's much higher than that, so that's very good. Now, but what I haven't discussed is the increase in intensity of toothbrushing. It's not like each health board just started. It gradually came up. So how do you deal with that? It's a wee bit of a statistical issue. So next, so here's one health board, Ayrshire and Arden. So the vertical line is time 0, which in this case is 94. The blue line is the toothbrushing going up. The black line is the toothbrushing coming down. So what we're looking for after T0 is for toothbrushing to come up, a DMFT to come down. So next, and we'll just go through all the health boards. Next. So as you can see that pattern in each health board separately. Next. Next. So that's Forth Valley. Next. Galloway, sorry, Grampian. Next. That's the big one, Greater Glasgow and Clyde. So as you can see, this crossing pattern does seem to be, you can see that in each health board. Next. 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 That's Lothian. Next. Orkney. Next. 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 Now, this one is a bit unusual, as you can see. Tayside, their drop is just before T0. That's because they had other things going on locally in that health board that started before the toothbrushing rollout. So next. So back to the problem. So what we did was next. So you've got the increase in trend for toothbrushing. Next, decrease in trend for DMFT. So next. So we did a meta-analysis. We correlated these 15 sets of paired slopes and weighted them by population size. So next, here's a bubble plot, which is big bubbles is big boards, small boards. And as you can see, there's a very strong trend there. Next, and apart from that one, that's Tayside, which is anomalous. So next, so the correlation coefficient weighted in all the boards is 0.64, which is quite strong, significant. But of course, if you exclude the Tayside board, it's minus 0.9, which is an extremely strong correlation. So we also looked at other things that might be going on at the same time as the toothbrushing. And there's no real evidence that any other intervention in that age group could be responsible for that improvement. Next, we also looked at other health outcomes. That's DMFT coming down in green. Previous, please. Previous slide. Yeah, and hospital admissions for non-dental things is going up actually, and obesity is flat. Next. So we did conclude that toothbrushing was associated with a very strong decrease in oral DMFT. Next. And next, we also did a cost analysis of the toothbrushing programme to see if, you know, how the benefits panned out against the costs of the programme. So we used, in collaboration with health economists. Next. So we estimated the programme costs in each board. Next. And then we also looked at the treatment costs. Next. Next. So, and of course, if you can save treatment costs, that might pay for the cost of the programme. Next. And here's a summary of the cost analysis. Now, the top line, the blue bars, that's the cost of the programme. The green bars underneath are the savings from the programme. And as you can see, gradually, the green bars are now much bigger than the blue bars. And that means that the toothbrushing programme is actually saving millions of pounds. And nowadays, that green bar would be even better because, of course, DMFTs continue to improve since this data was analysed. So in conclusion, next. So in the 8th year of the toothbrushing programme, the savings were more than 2.5 times the cost of the programme implementation. So next, so next again. So in conclusion, this toothbrushing programme really works and also saves the National Health Service millions of pounds. Next, so next. So who's next to attempt a toothbrushing programme like this nationally in schools? And I think we've shown that you can achieve really good results. Thank you. That's the end of my presentation.
Alex, thank you very much. And Childsmile has gained a reputation. I think your team has done two things. One is shown the oral health improvement, the reduction in DMFT, but it's also shown the potential cost savings, which has been very impressive. And I suppose that those two issues have been the reason why other boards, health boards, have all begun to adopt it. So I think that's been a very impressive ingredient, that if we are to introduce toothbrushing campaigns, then if we collect that type of data, it does attract other areas to embrace the issue. So where do you think did you introduce into Childsmile fluoride varnish or any other interventions? Sorry, you're still muted. We need to unmute you. Go ahead, Alex.
Right, yeah, Childsmile now includes lots of other things as well as the toothbrushing. And in the post-toothbrushing era, we're currently evaluating fluoride varnish and the other parts of Childsmile as well, and putting them all together to work out which parts of Childsmile may or may not work.
And this is all done in the school setting?
Well, other parts of Childsmile are at home before you go to school and in dental practices as well.